Assalamualaikum warahmatullahi wabarakatuh dan salam sejahtera saya ucapkan kepada semua hadirin yang dapat bersama-sama kita dalam sesi webinar kesihatan mental pada hari ini. Saya Dr. Nur Faizah binti Muhammad Tauhid merupakan moderator anda untuk hari ini dan saya amat mengalu-alukan kehadiran anda semua untuk bersama-sama kita mengetahui sebersedikit tentang tajuk yang akan kita bincangkan pada hari ini. Pada hari ini, CME kita adalah berkisar tentang tajuk masalah untuk tidur. Ya. Bagaimana seorang doktor di primary care menghadapi, bagaimana seorang doktor di primary care akan manage pesakit-pesakit yang menghadapi masalah tidur ini. Mungkin mereka tidak cukup tidur, susah untuk tidur, ataupun terganggu waktu tidur mereka. Ya. Dan apabila mereka ini yang selalunya akan diberikan dengan ubat-ubatan berkaitan tidur, selalunya ubat tidur, ya, kemungkinan juga mereka akan menjadi dependent. Mereka sentiasa memerlukan ubat-ubatan ini. Dan ada di antara mereka yang menjadi ketagih untuk sentiasa mendapatkan ubat tidur ini, ya, walaupun mereka sudah tidak mengalami masalah tidur lagi. Dan kadang-kala mereka ini akan mengunjungi klinik ataupun primary care physician ini dengan berulang-ulang kali. Dan ini tentunya mewujudkan satu masalah terhadap primary care doctors ini. Untuk membincangkan tajuk ini, kita amat bertuah kerana bersama-sama kita ialah seorang pakar psikiatri daripada International Islamic University Malaysia, IIUM, iaitu Dr. Muhammad Faiz Tahir yang akan memberikan kita lebih pengetahuan bagaimana untuk menghadapi pesakit-pesakit yang menghadapi masalah tidur ini dan mungkin juga mengalami masalah dependent terhadap ubat tidur. Terima kasih Dr. Faiz sudi bersama kita. Dan saya serahkan sesi ini kepada Dr. Faiz untuk presentation yang seterusnya. Silakan.
Baik, terima kasih Tuan Faizah Tauhid atas pengenalan tadi. Ini kali kedua kita bertemu di siaran, insya-Allah. Baik. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera kepada semua hadirin pada hari ini, insya-Allah. Hari ini saya akan berkongsikan tentang isu tidur ni. Jika ada permintaan untuk lebih banyak bahasa Inggeris, sila maklumkan di ruangan chat. Jika permintaan untuk bahasa Melayu juga sila kongsikan. Saya tak pasti mana satu yang anda semua lebih selesa lah. Ya. Baik. Saya akan share slide, walaupun saya tak minat slide, tapi supaya kita boleh sama-sama be on the same page. Mungkin saya pass ke Dr. Faizah, boleh ke? Dr. Faizah?
Boleh share. Boleh. Silakan share.
Di slide ni boleh ambil buat balik lah. Saya ambil pun kat internet je pun. Just untuk kita ni. Saya share ni.
Kita dah enable dah sharing slide.
Saya pass kat Dr. Faizah.
Oh, ada kat
Tak
saya.
pandai lah. Dah bawa je pass. Okay. Boleh Ada Dr. Faizah?
Saya dalam proses.
Okey.
Lagi 30 saat.
No problem.
Mungkin boleh Dr. Faiz ceritakan sedikit apa itu masalah ni?
Masalah ini Okay. Whatever that I'm going to share is this from my own experience. Okay. I understand there are a lot of articles and journals that we can read, no problem. But I think what I'm going to share for this afternoon is basically what I see at the clinic. Okay. So untuk menjawab soalan adakah benda ini common atau tidak, dia bergantung beberapa perkara. Dan perkara itu kebiasaannya adalah apakah punca-punca yang berkait dengan masalah tidur ni. Okay, apakah punca-punca yang berkait. Kalau saya boleh nanti Dr. Faiz akan sharekan slide tu. Alright. Now, bila kita sebut tentang punca-punca, bila kita sebut tentang perkara-perkara yang berkait dengan masalah tidur ini, kita tak boleh lari daripada classification lah. Okay. Dan untuk petang ini kita akan lebih menggunakan classification mengikut DSM-5, DSM-5 criteria for sleep disorders. Dr. Faizal, slide tu ada ke?
Ada, tapi belum boleh buka.
Ada share?
Ya.
Okay, tak apa. So di dalam DSM-5, nanti boleh tengok dalam slide. I'll go back to the slides. I'm just going to talk about insomnia disorder. Okay, masalah tidur, insomnia. Kerana ada beberapa kategori lain seperti hypersomnolence disorder, banyak tidur, narcolepsy, breathing related sleep disorder seperti obstructive sleep apnea, central sleep apnea, sleep related hyperventilation. Ada juga tentang sorry. Ada juga kategori circadian rhythm sleep wake disorders, kategori parasomnias, restless leg syndrome, dan juga substance or medication induced sleep disorder. Okay, so banyak kategori kat sini. Kalau boleh bagi tahu, tak boleh. Saya pun tak boleh share dekat sini.
Okay, dah boleh, Dr. Faiz.
Okay, thank you. Can you just open slide number 2? Okay. Next slide. Okay, so ini yang saya sebutkan tadi. Next slide, please. So you can see that I will just discuss atau bincang hari ini tentang insomnia disorder. We're not going to touch other categories of insomnia because I don't think we can do that in 1 hour. But at least we know that we're focusing on one category which is in the DSM-5 classification. Of course, ada juga ICD-11 punya classification, but for simplicity sake today, we'll just go on with the DSM-5 classification. So you can see there are a lot of categories there. We're just going to focus on one. Next slide, please. Now, there are various ways to define insomnia, but what we can learn here is that it is defined. Insomnia is defined as a repeated difficulty with sleep initiation. Maknanya dia nak mula tidur pun tak boleh. Berjam-celik. And then there's problem with maintenance. Some people, they boleh fall into sleep, but they cannot maintain for long. Maknanya, dia tidur mungkin 40 minit, terjaga. In our words, maybe we call tidur ayam mungkin. Some people have problem with consolidation and some with quality of sleep. Okay. And this problem occurs walaupun, even though there's opportunity for sleep. Okay. Ayat ni penting because kita nak lihat sometimes orang kata dia tak boleh tidur. Okay, kata saya ada masalah tidur lah doktor, tapi sememangnya dia tak boleh tidur kerana dia mungkin bekerja sebagai pegawai perubatan, kan, yang tak ada opportunity untuk sleep, shift work, being on call dan sebagainya. So dia tak ada opportunity untuk sleep dan dia tak boleh tidur. So we don't really say that that's insomnia in that sense. Okay, so dia kena ada adequate time and opportunity for sleep. Dan jika tidak boleh tidur, such as sleep initiation tak mampu, maintenance tak mampu, consolidation tak mampu, maka then we might consider this as insomnia. There are a few other criteria that we're going to look through, but these are the main things that we need to understand. And when they can't sleep, the next day they will result in some form of daytime impairment. Maknanya in the morning tu dia punya function tu tak seperti biasa lah. Okay, so we need to have these things in order to say that this is insomnia. Next slide, please. You can post questions in the chat if you need to. Okay, this is the full DSM diagnostic criteria for insomnia disorders. You can see that it states that dissatisfaction, tak puas dengan quantity ataupun quality tidur. At least, ini paling penting, at least 3 malam in a week. 3 malam in a week. Selama 3 bulan. Alright? And associated with either number 2 to 6. Sorry, the 3 on the next. Number 1, susah nak terlelap, difficulty falling asleep. Number 2 is difficulty staying asleep, maknanya maintenance tadi. Frequent awakenings, dan kalau dia dah bangun, dia susah nak tidur balik. And also, we talk about early morning awakenings, maknanya dia bangun terlampau awal pada waktu pagi. And insomnia, the other criteria would be that this condition, okay, causes significant distress or impairment. Okay, maknanya dengan keadaan tak boleh tidur ni, dia punya kerja-kerja harian, dia punya function, occupational ataupun academic, social dia, dan juga the personal function is impaired. And insomnia, okay, one of the other criteria is that it occurs even then where there is enough time to sleep. So kita bayangkan kalau pelajar ni orang ini seorang pelajar di sekolah asrama di mana ada lights off pukul 11 malam hingga 5 pagi adalah waktu tidur, masa diberi, tak ada bagi kerja apa, tak payah on call, tak payah buat grab ke apa, perlu diberikan waktu tidur, tak boleh tidur. Okay, insomnia. And it does not occur exclusively during, maknanya tidak berkait dengan narcolepsy, tidak berkait dengan breathing related sleeping disorders, tidak berkait dengan circadian rhythm sleep disorders ataupun parasomnia. Okay, and it does not occur exclusively, okay, during the course of another mental disorder. Kita akan lihat other mental disorder itu seperti apa. Umumnya kita cerita tentang major depressive disorder, kita cerita tentang anxiety disorder. Okay, these are the main things that can cause sleep impairment. And the other thing is not due to any direct physiology effects of drugs. Some people, they make drugs, they tak boleh tidur, so that would be the culprit. And so we don't really call that as insomnia. Next slide, please. Right. This is just the same thing. So in short, we need to understand that insomnia, patients will come and complain, doktor, saya nak lelap pun tak boleh, cannot even initiate sleep. Doktor, saya dah terlelap, tapi sekejap saja saya dah bangun. They're not able to maintain sleep. Dan doktor, bila saya dah bangun tu, saya susah nak tidur balik. Susah nak resume sleep. Okay, this is from the American Psychiatrist Association 2013, and I still use this to this day. Ada some people macam kita kadang-kadang bila kita terbangun tengah malam, pergi buang air, semua minum air ke makan dan sebagainya. Makan tak lah kot, buang air, minum air sikit, kita boleh resume sleep. But for some people who have insomnia, they can't resume sleep. Okay. And the quantitative criteria kita mention tadi, 3 nights in a week and 3 months. So then, bila dia fulfill criteria ni, dan kita insomnia. So maknanya kalau dia kata doktor just 2 malam seminggu and then baru sebulan setengah, I mean, to me, it's insomnia in progress, kan? Right? I would still treat. Okay, tapi kalau confirm 3 malam, 3 bulan in that year, then we can say this is insomnia already and we should treat. Okay, next slide, please. Okay, same thing. We need to consider rule out mental disorders, medical disorders, other sleep disorders, and also whether this is due to drugs or medication. Okay, next slide, please. These are mainly North American numbers, also similar to some UK numbers. So insomnia, almost 10 to 50% of the population are affected. All right, so Malaysia, we have 30 million, so we can do the maths. Okay, ramai lah. Ramai yang, okay. Okay, Doctor. So how do I move the slide? Oh, okay, okay, all right. Okay. And 20% of adult population have chronic insomnia. 20%, maknanya kalau ada 5 orang, kita pergi buat gathering, maybe one of us would have chronic insomnia. And chronic insomnia increases with age, and is twice as common in females. Okay, so yeah, lah nak kena jaga anak, jangan anak kecil lagi kan. So this is quite a challenge. We respect that from the guys. And then age is more than 30 years, more than 70 years. Okay, so the age will increase age, then increase prevalence of insomnia. Okay, okay, go to the next slide, please. Baik. So when you see insomnia ni, kita katakan how does it affect, number one, the individual? How does it affect the family? How does it affect the organization that these people work in? And how does it affect the nation? Okay. Kadang-kadang kita katakan bahawa susah tidur, tak ganggu siapa pun, mungkin individu itu saja yang terkesan, tapi tak sebenarnya. A lot of people terkesan, even up to the country can be affected. So you can see that insomnia has a detrimental effect on health. This is a North American punya ni, US punya figures. Has a detrimental effect on health related quality of life, okay, to the same degree as chronic disorder such as depression and congestive heart failure. Maksudnya orang yang ada insomnia ini, dia punya quality of life ni hampir sama keterukan atau signifikan dia macam orang yang mengidap chronic disorder seperti depression dan juga sakit jantung lah, congestive heart failure. And the economic costs that encompass healthcare use, absenteeism, accidents, and also increased alcohol consumption. Some people, they cope with alcohol. Maybe for us in Malaysia, we cope with smoking, with vaping, with taking ketum dan sebagainya. So in the US, it's around, the cost is around 35 to 107 billion. So kalau kita ambil Malaysia, maybe if you take 10%, that'll be around 3 billion to 10 billion dollars. That $10 billion lah, tukar Malaysia, ringgit Malaysia lagi, then you can understand the figures. And this was the figure in 1994. Of course, there will be higher figures nowadays, we would say that. So when you can't sleep, you can't go to work, and if you do go to work, what we call sebagai presenteeism, you can't really function optimally. So ini kerugian kepada organization. And we do know cases of some of our members of the fraternity have microsleep. Some are involved in accidents, some also involved in fatal accidents. So these are the things that we need to consider when looking at insomnia. Next slide, please. Right. So these are the psychiatric disorders and conditions associated with insomnia: major depression, dysthymic disorder, again, a form of depressive disorder, bipolar disorder. We also have people with anxiety, generalized anxiety disorder, panic disorder, PTSD, post-traumatic stress disorder, schizophrenia, also substance use disorders. These are the disorders from the psychiatric category which have problems with sleeping. And there are also medications and substances associated with insomnia, such as alcohol, caffeine, nicotine, cannabis, antidepressants, and the list goes on. Next slide, please. So what are the factors related to insomnia? Number one, individuals with insomnia often have minor elevations in depressive and anxiety symptoms. We do see this in our practice. And also from the social environment factors, insomnia is often precipitated by social or environmental stressors. This is very important to understand, because when our patients see us at our clinic setting, we need to understand what are the stressors that they are facing at the moment. And those stressors are actually the ones that are contributing to the insomnia. In other words, if we are able to manage the stressors, then the insomnia would improve with or without medication. And it's best that we don't use too much medication kalau boleh. Next slide, please. Right. So these are types of insomnia as classified by the National Institute of Mental Health Consensus back in 1984. There are terms they use such as transient insomnia, they use short-term insomnia. So these are just differences in durations of not being able to sleep. Okay, just technical stuff. Next slide, please. And also long-term insomnia, something we see more than 3 weeks. But we'll just to remind ourselves, we just stick to the one insomnia disorder by DSM-5, 3 weeks in 3 nights in a week, and also 3 months, and then the inability to initiate and also maintain, also resume sleep. So we'll stick to that. All right, continue. Next slide, please. Okay, Spielman, dia punya 3 P's of model of insomnia: the predisposing, precipitating, and perpetuating. These are the things that we use quite a lot in psychiatry. The predisposing factor, the precipitating, also perpetuating. And you can see there that we want to look into whether this patient already has some form of mental disorder, such as major depressive disorder or any other depressive disorders, or any other anxiety disorders, namely generalized anxiety disorder, panic disorder, and also post-traumatic stress disorder. We want to ask about the sudden change in life, sudden change in schedules, if they're taking any medications or substances, and if they are having any medical conditions. So these things can precipitate insomnia. And what are the perpetuating factors? Generally, what Spielman outlined is the poor sleep hygiene, meaning to say that we do need to ask all our patients about their sleep hygiene. We'll get to that in a while. Next slide, please. Okay, I use this quite a lot with my patients. Number one is a sleep diary. Okay, you can design the sleep diary as you want. For me, it's just basically time, date, and then when do they go to bed, how long do they sleep, and then when do they wake up, and some notes there just to know what the pattern is like, because basically when we're dealing with patients having these kind of disorders, the pattern is very, very important, and you can't get much. I mean, especially in GP, you probably don't see patients long enough, which I understand why, so that when they come and they show you the sleep diary, it's just going to make things so much easier for you. It's just like macam tunjuk buku dia yang dia catat dia punya blood pressure, catat dia punya glucose. So it saves a lot of time, and we could focus on other things about the management. Actigraphy, some patients, this is a portable device around the wrist. I think a lot of people do wear watches or devices like this nowadays. How we're going to extract the data, it depends on the device, but I've not personally extracted any data from my patients. I've just used a sleep diary, that would be enough. And the other one is polysomnography, ataupun sleep study. Most recently, one of my patients did a sleep study in a private hospital in KL. Okay, and then they got the results. But basically, the people who do interpret sleep study ataupun polysomnography ni are sleep medicine specialists lah. I don't do interpretation. I just look crossly just to get an idea of what the problem is. But basically, the analysis and the suggestion should come from the sleep medicine specialist. All right. Next slide, please. Sorry about that. Now, I guess that we're all here just to focus more about the treatment. Okay. We'll see what the treatment goals are. Of course, number one is to improve the quality and the quantity of the sleep of our patients, and to reduce the sleep-related distress. And indeed, we need to help the patient to improve the daytime function. All right. Why I'm saying this is because sometimes, we are able to help the patient sleep. They put the insomnia, and then they are able to sleep with either with medication or non-medication. But more importantly, when we do give the patient medication, they are able to sleep, but they are not able to function during the day because of the side effects of the medications. Maybe the dosing is not suitable for the patient, so they don't really function well during the daytime. And then our treatment goals is not quite optimal in that sense. So treatment goals to improve daytime function, meaning that we need to find that optimal treatment strategy, especially medication, so that the patient will be able to function in the daytime. There are somatic treatments, or what we call now what we say as medications, like benzodiazepines, tricyclics, melatonin, antihistamines, and barbiturates. I'll just mention which one that I normally use. I don't use all. I'm not familiar so much with other medications. And the third category is psychosocial treatments, such as stimulus control, sleep restriction therapy. These are the non-medication type of management. Relaxation training, cognitive restructuring of irrational sleep-related beliefs, and sleep hygiene. Basically, it's CBT for insomnia. I also don't do this, and I usually refer this to psychologists that do CBT for insomnia. Okay, next slide, please. And most importantly as well, sleep hygiene. It's something sometimes we forget to talk to the patient about sleep hygiene. Sometimes we are just in a hurry to give medication, but sleep hygiene does help a significant number of my patients to get to overcome the insomnia. So number one is avoid naps during the day. Okay, and number two is to have regular exercise. We all know that after good exercise during the day, we are likely to sleep better at night. Okay, sounds testimonial, but there are a lot of articles that discuss this, and these are the things that we need to share with our patients. Maintain a regular sleep schedule. Okay, we all have this problem. I have this problem as well. Okay, but we try to stick to it as best as possible. It's not just maintain a regular sleep schedule, but also maintain a proper place to sleep. Because sometimes some of us have the habit, or our patients have the habit of sleeping on the couch, sleeping in front of television, on the carpet, sleeping, just about everywhere or anywhere. So we need to ask them to maintain regular schedule, and also regular location ataupun bed to sleep in. I can't really talk too much on this because I don't have a regular sleep schedule or sleep location. Not that I'm sleeping around, I'm just saying that sometimes I do sleep on the couch, sleep in the car and so and whatnot. Okay, not the best person in this category. Avoid stimulants. Okay, some people they take caffeine or they smoke before they sleep, and these are the things that we just want to inform them that they might want to try not doing this for a couple of weeks, and not just a couple of nights, but a couple of weeks, and see if there are any differences in that. Limit alcohol intake, and some do suggest do not look at the clock when awake in bed. Okay, masuk tidur pukul 11, 11.30 tak tidur lagi, 11.45, 12.1. Okay, we try to avoid that, meaning that we ask the patient not to look at the clock or watch or whatever before they sleep. The other one which is discussed quite fairly is about gadgets, before we sleep. But some would go to the point that it's not just when you're about to sleep. Maknanya if you sleep at 11 malam, you don't look at your gadget starting from 9 p.m. onwards. It's difficult to do, kan? You know, we would probably look at our gadgets anyway, even half an hour before sleep. But it's not just about the 1 or 2 hours before sleep. It's also about during the day, because all these gadgets, the television, our LCD from the laptop, and also the phone, they emit blue light. You know, blue light. Some people do buy devices that would cut off the blue light, because the blue light would have effect on the melatonin secretion, which for some people it would just make our sleep cycle haywire. So that's why they advise not to use the, welcome back Dr. Faiza, use or be exposed to blue light even 6 hours before sleep. Okay, but I understand it varies from people to people. Next slide, please. Okay, this is non-pharmacological approach. Okay, I mentioned CBT for insomnia. I'm just mentioning this. I don't even do CBT for insomnia. Okay, and it's about stimulus control therapy, sleep restriction therapy, relaxation training, cognitive therapy, sleep hygiene education. We would need to probably invite a psychologist that does this to speak in length about this. Next slide, please. Okay, this is the same thing. Exercise during the day, no more than 4 to 6 hours before sleep. I understand that some people do exercise at 10 p.m. and they expect to sleep at 11. Some people are able to sleep at 11, but some people can't. So these are the things that we need to discuss with our patients. We need to keep the bedroom dark and quiet, and only for sleep, because we know that some of our patients, they use it for, you know, all sort of things, Netflix lah, main game lah, you know, Zoom meeting and sebagainya. You know, this is something to do with the psychology and also behavioral science lah. Okay. Curtail time in bed to only when sleepy. Okay, so when you're sleepy, then you go to bed. If you're not sleepy, then don't go yet. Okay, and fixed sleep wake times, schedule sleeping hours. I mean, for certain religions, especially if I can talk on Islam, you know, we have all the prayer hours. So it's good. It's a good way of scheduling ourselves to be what time to be awake, what time to sleep, and so on and so forth. Okay, there are a lot of there are a lot of evidences, a lot of Quranic verses on sleep, but probably I would share some other time. Avoid naps just now. Stimulus, avoid stimulus, alcohol, no caffeine, no alcohol, no smoking before sleeping. And some might say light snack before bedtime. It works for some people, it doesn't work for some other people. So that's why it's important to always talk to our patients which one helps them to sleep. Some people, they kena minum susu sikit ke sebelum tidur. Some people can't take anything before sleep. So these are the things that we need to understand, the variation of individuals. Next slide, please. We have 25 minutes to go. I'll get to the medication in a while. Okay. We can ask a patient to use the bedroom for sleep, as mentioned just now. Go to bed only when sleepy. Remove clock from the bedroom to avoid constantly watching it. Some clocks, not the digital ones, the analog ones, they tick. And we can sometimes listen to it tick, 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 tick. Lagi lah tak boleh tidur. So these are things that we want to ask our patients. Light therapy is required. I've not done this before. And no bright lights when you wake up at night. So the rationale is, if you have bright lights, then it will be difficult for you to go back to sleep because of the stimulus to the structures of the brain that regulate sleep. Next slide, please. Okay, I think you can read this later on because I want to go straight to medication. Takut tak cukup masa. Also, I'll skip this one. No, let's just go to type 23. Yeah. Okay. You know, to be honest, I haven't really referred anybody or come across anybody that has gone to cognitive therapy or relaxation therapy for sleep. Maybe they have, but I haven't come across any. Or maybe indirectly that we've met patients who are overly anxious, who have panic disorder, general anxiety disorder, that have catastrophic thinking. You know, they have certain thinking patterns, they have thinking patterns that, you know, causes them not being able to sleep. And this CBT would help them to reduce those uh, unhelpful thinking patterns and promote better sleep. So that's the idea behind it. But I haven't done it personally. All right, next slide. Okay, I think this is the juicy part of the most people probably want to know about the management in terms of medication. I'll share with you my experience, and I'll just touch a little bit on what's available on the slides. So there are benzodiazepines, there are non-benzodiazepines, there are melatonin receptor agonists, the new antidepressants, if you may. There are antidepressants, antipsychotics, interestingly, and I love it. Antihistamines and opioid drugs. We won't go to opioid drugs. Okay, next slide, please. Okay, these are the benzodiazepines, as you can see. And not all are available in Malaysia, the US slide. So I'll just pick on which are the ones that I normally use. What I normally use would be clonazepam. I use a lot of clonazepam. It's long acting. I seldom use lorazepam. I only have one patient on midazolam. Not really my patient. It was just a handover from another therapist that moved elsewhere. And the patient is dependent on midazolam and also dependent on aprazolam. So basically, I do use midazolam and aprazolam for this one patient only. For this one patient only. The rest of my patients, I use clonazepam. I'm not saying that midazolam or aprazolam is bad. I'm just saying that, you know, for my treatment strategy, I try to avoid using midazolam, especially. I try to avoid using aprazolam. I use a lot of clona. So if we do want to discuss further clonazepam, we can always do that. Next slide, please. All right. So later on, you can see the peak blood level, the elimination of half-life. This is from a technical point of view, but what is most important that we ask our patients, what time do they take the medication? For instance, they take clonazepam. What time do they take clonazepam? What is the dose? Okay. How long are they able to sleep? And do they wake up feeling drowsy or lethargic in the morning? Or do they feel satisfied with sleep or not? So these are the main questions that I ask them. So then we could actually adjust the dosage of the medication, and we could adjust the timing of the person taking that medication. And it kind of works well with the patients. Okay, so again, I use a lot of clonazepam. I'm not selling clonazepam, I'm just stating my preferences. Next slide, please. Hang on, that slide tadi. Okay, you can see down there, zolpidem. We use a lot of zolpidem as well. It's a non-benzodiazepine. Some people call it the Z medication. Okay, next slide. Okay, so how does the benzodiazepine and non-benzodiazepine act on the body or act on the sleep cycle specifically lah? Okay, so basically the benzodiazepine is partial disruption of the non-REM ratio. You know, we have to go through the sleep cycle, but it's going to take some time, but you know, the action is there. I would love to go through the sleep cycle, but I don't think we can do that. So hopefully, if you have any questions, we could discuss that. But I'm not an expert in that sense. I would love to you know, we would love to invite sleep medicine specialists to talk more on this. But you know, what I can say is that as far as from a clinical point of view, we need to rely much on the patient's report about the quality and quantity of sleep. Because of course, if we don't have a polysomnography, we won't be able to see what kind of sleep cycle ratio that they have. Okay. Excuse me. All right, next slide, please. Now, we do have to be aware of the adverse reactions of benzodiazepine, okay, especially clonazepam, because it's a long-acting agent. For instance, if the patient is to take clonazepam of a certain dose at midnight, all right, and then they would report feeling drowsy even 8 a.m. or 9 a.m. the next morning. Okay, so these are the things that's very challenging. These are the things that we need to psychoeducate a patient about when to take the medication and at what dose and what we're trying to achieve. It helps to discuss this with the patients. Adverse reactions such as daytime sedation, seen quite a lot. Cognitive impacts. These are the things seperti patient kata dia mudah lupa, mudah nak faham certain things. They feel sluggish. This happens with benzodiazepines, right? So between the long-acting agents and the short-acting agents, later on with experience, we can see which patient category that we can kind of use the long-acting or the short-acting. But for me, I prefer the long-acting at the moment. Okay. Next slide, please. I'll answer the questions later. Thank you. Okay. When we talk about advanced age, for elderly population, I try to avoid using benzodiazepine. Okay, if I do the benzodiazepine, it's going to be very super low dose. Start off super low dose. We'll discuss the dosing at the end of this presentation. Respiratory distress with low dose, I don't really see respiratory distress, which is good. Okay, and you normally see this with high doses, but at low dose you don't see that. Am I worried about patients abusing benzodiazepine? Of course, yes. And that's why during the discussion with the patient, we need to, at the same time, can we mute the one that's the Faiza? Kind of distracting.
Okay.
Everyone. Thank you. Okay, where was I? What was the other desperation? Oh yeah, do we need to discuss with patient and we need to evaluate whether this patient is having a high risk of overdosing or not. So this is going to be a bit tricky. Okay. You can ask questions later on that. Benzodiazepine poisoning, I haven't seen so far, alhamdulillah. Okay, and even though should the patient have benzodiazepine overdose, we know that the antidote is flumazenil. Okay, so keep that handy. If in your clinic, keep that handy in your clinic. Next slide, please. Okay, dependence. Now, dependence, some people, I mentioned to you, one of my patients, transferred to me patients, aprazolam and midazolam, highly known for dependence, okay, and mainly because of the downregulation of the GABA receptors, a bit of pharmacology there, okay, meaning that if you still try to reduce the amount of dose of aprazolam or midazolam, patient won't be able to get a good quality sleep. They're going to be maintained on that dose, and for some patients who are more unfortunate, they will need higher doses. So that's what we're trying to actually avoid. Okay. Dependence occurs with taking these medication for prolonged periods of time, especially drugs with short to medium half-life, aprazolam, midazolam. Have I seen dependence with clonazepam? The patients under my care. I could probably say that some of them decide to reduce their dose, to reduce their frequency, and eventually decide not to take clonazepam anymore because they don't have any sleep problems. Okay, and these patients are basically the ones who have major depressive disorder and patients who have anxiety disorder. I don't have so much of patients with pure insomnia disorder, not so much, so that I can't really speak on their behalf. But for patients who have anxiety disorder, depressive disorder, major depressive disorder, they are able to wean off clonazepam. All right. Also look at the dependence, look at the withdrawal symptoms. When they don't get the medication, they'll be in state of anxiety, they will have rebound insomnia, they become restless, agitated, sometimes irritable and angry. So these are symptoms of dependence. Next slide, please. Okay, the tolerance to the sedative effect develops slowly, or the mechanism is not very well understood, and it's postulated maybe due to self-induction of benzodiazepine. Okay, these are the things that we don't clearly understand. And we also need to understand the medication about the drug-drug interaction, which are the medications that would increase the metabolism, and which are the medications that would reduce the metabolism of benzodiazepines or other medications for that matter. So in this case, the enzyme inhibitors like ketoconazole enhance benzodiazepine action, meaning to say that if you give a certain dose, because the enzyme, the CYP3A4-2C9 would be inhibited, therefore it would appear as though relatively that you're giving higher doses of benzodiazepines. And there are also blockers for these enzymes. Sorry, like smoking, also aminophylline. Okay, so we need to understand the drug-drug interaction. But just to keep things simple, with a low amount of clonazepam that I use, there's not much of differences that the patients report in terms of whether it becomes deranged with their lifestyle, such as if they're smoking or they're taking other medications. I don't see that much significance. Next, please. Okay, benzodiazepine or zolpidem. Zolpidem, normally the average dose we give is on 10 milligram. Some people might give 5 milligram. But the thing is, we have to be aware that since they are generics, if yang kita guna zolpidem, yang the nice ones is what we call Stilnox. And Stilnox is 10 milligram. That one is original. You give 10 and patient would actually be able to achieve good quality of sleep. But now, since they are generics, even if you give 10 milligrams, they're not really achieving the same effect as when you get the Stilnox. So sometimes I do increase it to 15 milligram, slightly higher. Some patients do need 20 milligram, but I will continue to monitor in the short to medium long term to see whether the patient would need to have a change in the management strategy. Okay, because it's not for everybody. Next slide, please. Okay, antidepressants. Some patients who have anxiety disorders or depressive disorders, and if they have sleep problems, we would want to provide an antidepressant which has sedative properties. Okay, which has sedative properties. And I mainly use fluvoxamine. Luvox, the trade name is Luvox or fluvoxamine. I don't really use TCAs. I don't really use amitriptyline, mirtazapine once in a while, but doesn't quite help in the patient that I see. Next slide, please. So you want to use, next slide. Okay, you want to use fluvoxamine. Is to me is kind of safe to use. You can start with 50 milligrams, can go up to 100, some people 200, but for sleep purposes, sometimes it's around 50 to 100. Okay, just to assist them for a short term. Short term is anywhere around 1 month to 3 months. That for me, short term. Escitalopram, though it's stated is less sedating, but some patients do get rather significantly sedated with escitalopram. We just have to go with the patient's report. Don't force it onto them. Don't say that it's just you, other people. Okay, I know I don't really do that. If they say it's too sedating for them, then we need to consider other medications if we're not looking for that sedative effect. But for patients again who have issues with sleep and they have anxiety, they have depression, I would normally use fluvoxamine. The other one new drug recently, maybe 5 or 8 years ago, is the venlafaxine. Okay, some people also use venlafaxine to help patients in sleeping, because it's like a double-edged sword for anxiety and also depression as well. Okay, so these are the things that I normally use. All right, amitriptyline, trazodone, I don't normally use that. Mirtazapine, on and off. All right, next slide, please. Now, antipsychotics. I think this is a kind of interesting part. You do see examples there: risperidone, olanzapine, quetiapine, ziprasidone. But the ones that are quite available would be the risperidone, quetiapine, olanzapine. Yes, but we're going to see that it does carry a little bit of problem when using olanzapine, such as weight gain, metabolic effects in the long term, highly sedated. Then there is risk of extrapyramidal side effects. Okay, not as bad as using first generation such as haloperidol, but it's still there. Okay. So what I want to highlight here is how I use quetiapine. Okay, quetiapine to assist patients with sleep. Just remind me 5 minutes at the end, I'll share with you a case that I'm treating with patients with this combination. Okay, next. Okay, I'll reply to you soon, Faria. Okay, antipsychotics, let's put it on the table, not FDA approved for insomnia. It's not. Okay. Typically used at doses much lower than those for treating psychosis. That is correct. Seroquel, for instance, if a patient has schizophrenia, you need to treat them at an acute stage. 600, 800 sometimes, 600 to 800 milligrams is sometimes not enough. No, not enough. Patient who have bipolar, we go to 1 gram sometimes. Okay, maintenance will be around 400, 600, depending on patient to patient. What I'm trying to say is that the ones that I use to assist with sleep would be around, there are as low as 12.5 milligram, 25 milligram, 50 milligram. So you can see it's not really that high in that sense. Okay, I don't use risperidone for patients with sleep disorders. I don't really use olanzapine that much, and we don't have ziprasidone that readily available. Okay, so basically it's quetiapine. Okay, I'll share you the case to give you an idea of how much dose that we use, but that's just my experience. This is for learning purposes. This is not to be used as a guideline ataupun a medical advice. Okay, boleh fair enough. So antipsychotic sums are quite sedating and associated with weight gain. This is very true for olanzapine, Seroquel as well, but olanzapine is the biggest culprit. Increased risk for diabetes, again, olanzapine, high blood pressure, olanzapine, muscle spasm, Parkinson-like syndrome, olanzapine, risperidone, quetiapine to a certain degree, but I haven't seen that with low dose of quetiapine. Okay. So it's stated here that quetiapine have been shown to increase total sleep time as well as sleep efficiency. So we probably need to understand that quetiapine, it will hit on certain receptors in the brain, and the one that we want it to hit for sleep is the histamine. Okay, the histamine receptor. So this is the one that we want. We don't want it to hit on the serotonin or the dopamine receptors. So low dose would normally go for the histamine receptor, which would cause that sedation. Continue. Almost to the end. Okay, you can see that this recent 2021 Cleveland Clinic Journal of Medicine, quetiapine for primary insomnia. We need to consider the risk. It reads there. The second generation is antipsychotic, which is quetiapine. Seroquel is the trade name. Is increasingly being used off-label. And the word is off-label. A lot of people are using it. A lot of countries, a lot of practitioners using it as off-label to treat insomnia. Okay. And they use this possibly to avoid the addiction of what we mentioned tadi, midazolam and also alprazolam tadi. However, evidence to support using it in the way is scant. It's not much. And quetiapine is associated with weight gain and other metabolic side effects such as hypertension, such as predisposing to diabetes. It must be used, let me say that again, quetiapine must be used cautiously and with appropriate monitoring for adverse effects and abuse. That was one of the questions. I'll get to that in a while. Next slide. If there's anything, these are the key points. Quetiapine affects multiple central nervous system receptors, resulting in a variety of effects, including sedation. That's what we want, that sedation part. The use of quetiapine to treat insomnia should be confined primarily to patients with comorbid mood or schizophrenia spectrum disorders, meaning to say that the indication for quetiapine is bipolar, is mood, major depressive disorder, is schizophrenia. So they're saying that, okay, since they already have those disorders, then if they can't sleep, then you can use quetiapine. You know? So it's kind of like uh, using it for two things. There are cases where patients do not have schizophrenia, do not have bipolar, do not have major depressive disorder, but they are given low dose of quetiapine. Okay. Okay, Kari, I'll get to it. Tabi. Okay, thanks. Okay. So when you use these antipsychotics, you want to monitor movement disorders. You want to monitor the weight. Always ask about their weight, record their weight, because when you start giving all this medication, you want to see whether there's any increase in weight due to the medications or anything else. There are cases where patients do gain weight when you start them on medications, but is it because of the medication that they gain weight, or is it because that their quality of life has improved? Boleh tidur lebih baik, selera makan pun ada dan sebagainya, boleh tidur lama, do they gain weight because of that? So these are the things that we need to consider. Of course, we won't find the cause, but we can find the associated factors. And also do an ECG, a preliminary ECG, because sometimes patients, when we start on antipsychotics, you do see QTC prolongation. Okay, so have that in mind. Record body mass index, weight, blood pressure, fasting glucose, and lipid levels, because if they were to get any side effects on medications, these are the parameters that we'll be concerned about. Patient would be obese, patient would be hypertensive, patient would have high glucose, fasting glucose levels, and they would also be having high cholesterol levels. Okay, so it's also stated that despite having no euphoric effects, meaning that patients take medication and don't feel like happy or excessively happy, quetiapine is often abused to enhance or counter side effects of illicit drugs. I haven't seen this in my practice. Maybe if you talk to addiction specialist, they might be able to elaborate this further. But as far as my practice is concerned, I don't really see people who are abusing drugs and also then taking quetiapine to counter the side effects of those drugs. I haven't seen that. Can't comment on that. 1 minute, thank you. Quetiapine carries particular risk for elderly patients. Please take note because we are very concerned about that. My oldest patient on quetiapine would be around 70 plus, a low dose of 25 to 50, I'm not mistaken. And she has mood disorder and she has also sleep disorder. But when we start on that, the mood improves and also the sleep improves. And we do know that a low dose of antipsychotic helps in augmenting antidepressants, meaning that to say if you're already given a good dose of antidepressants, patients are not improving in terms of mood, you just augment it with a low dose of antipsychotic, and then you can see probably significant changes. You can see probably improvements. Okay, so that patient of mine, 70 plus, did have mood disorder, and we kind of augmented it with quetiapine, and then she's doing quite well now. I haven't seen her for a few months already, so I think she's doing fairly well, I guess. Next slide, please. Okay, non-prescription antihistamines. These are the things that we do give at we means not in psychiatry. I mean, in probably GPs, there are some people who report that they give ubat batuk, ubat sesama to help with sleep. Yeah, they could help, but we have to see if is this an insomnia disorder or is this a patient already having underlying mental disorders such as depressive disorder, anxiety disorder, so on and so forth. Find the cause, and then you probably find the best treatment for this patient. Next slide, please. Oh, we're done. All right. So I'm just going to go through the questions bit. Thank you, Dr. Faiza, for reminding on the time. Okay. Bagi mereka yang bekerja shift hours, masa tidur yang berubah-ubah, what is your advice on this? This is something yang yang very difficult actually to manage. Personally, I would want to understand what kind of work that they have to do, what kind of job description, and then I would want them to discuss this with their supervisor. There will be a point where you will be seeing patients who would need to be on a regular sleep schedule, whether with medication or without medication. Meaning to say that if they start kerja malam, if they start kerja night work, then it will disrupt it. And when it's disrupted, they can't work at all. No, but we have to really do a thorough examination, because you do get patients who sometimes feign their symptoms. We can't run away from that. But that is why we mentioned just now the sleep pattern, the diet is very important for us to understand. It's very important for us to make a report. We can only do so much. Whatever happens, we don't know. Meaning to say that kalau patient tu sebagai contoh kerja sebagai nurse, and nurses need to do sometimes, not sometimes, quite frequent kerja malam, and then ada hari tidur, ada hari pelepasan, and some patients they can't go through that frequently. So I think the next thing would for us to do is to suggest kerja, what they call that, divided lah, kerja waktu siang kan. Maybe some people might not be happy with that, okay, but if we are able to establish that the patient has some form of sleep disorder, and that is the best for him or her, then that's what the organization or the supervisor ataupun ketua unit need to assist her with that. And in this case, I would definitely refer to sleep medicine specialist. At least they can do a sleep study, and they will have more facts and more information to help with the management of this patient. I would suggest that. Okay. So we can send to sleep study. Okay. Next, do we recommend pharmacological intervention for elderly with comorbids? Which agents safest for them? Okay, like I mentioned just now, but this is just my experience. I use a low dose of antipsychotics, in this case, a Seroquel. We already know that it's off-label. We already know that FDA doesn't approve. But as far as the symptoms is concerned, in terms of anxiety, in terms of depression, in terms of sleep, it does kind of help them with that. So, you have to weigh between the risks and benefits. One of the things that I probably might not start on my elderly patients would be benzodiazepines. Okay, because sometimes the sedation is so bad, there's a risk of fall. And then when you combine with a lot of medication, sometimes it just makes things more complex. The quetiapine itself has this risk of causing postural hypotension. Okay, so I don't normally add with other medications, especially benzodiazepine. Some might ask, would you give antidepressants and benzodiazepines without antipsychotics? So in this case, I would see what are the benefits between antidepressants, benzodiazepine, antidepressants, and antipsychotics. I will get a better bang for my bucks with antidepressant and low dose of antipsychotic in that sense, as far as what my current practice is concerned. Okay, because you would have that augmentation effect from the antipsychotic. You just have to use a low dose, and the patient reports being able to sleep better in that sense. With benzodiazepine, you don't actually get the augmentation effect for the antidepressants. So, of course, this is case-to-case basis, but for me and for this patient of mine, several of them are old age, this is the combination which I use. How long do you put patients on treatment, or can it be given PRN basis? Okay, thanks. There are patients who do benefit from PRN basis. There are patients who do benefit from regular basis, and most of my patients, I insist that they take this on a regular basis first, because what I want to see is that before treatment, what is their sleep pattern like? Okay, and they would have to produce some form of chart, sleep study chart. Sleep chart. And after initiating treatment, I want to see what is the pattern like. Okay, of course, you don't see the effects in the first 1 or 2 weeks. Sometimes it's still haphazard. You're still trying to perfect your dose, correcting your dose. So say, for instance, after 3 weeks or 4 weeks, they're able to sleep with the current regime that you have, whether it be an antidepressant, whether it be benzodiazepines, non-benzodiazepines, zolpidem, or with antipsychotic, then we need to record what is the quality of sleep, quantity of sleep, So meaning to say that they need to be on regular medication. After a while, when they have achieved sleep satisfaction, then we start cutting down the medications. And probably, you know, first to go usually would be clonazepam. Patient would say, no, I don't think I need benzodiazepines anymore. You know, the next thing to go might be antipsychotics, so on and so forth. But again, it would have to take into consideration what are the comorbidities that they have. You know, it's really difficult to just put on a rule of thumb basis in this sense. Okay, so to answer that, I would probably put on regular scheduling of medication and then later on cut down. Earlier you mentioned antihistamine is one of the treatment, meaning chlorpheniramine can be used for insomnia. I'm not sure what I said antihistamine is one of the treatment. Probably I just mentioned in the slides, but for me, I don't use that. I don't use ubat-ubat sesama to treat post-sleep dan sebagainya. Used to last time masa buat lokal biasalah itu je ubat yang ada kan. No, but now not anymore lah. Okay, not anymore. Is it safe for us in primary care to use benzodiazepine clonazepam for longer than 2 weeks? Safe in the sense of patient management, I would say yes, it is considered safe as far as my experience is concerned. And the dosage that I normally use, is just between 0.5 milligrams to 1 milligram on night. That's all. It's considered fairly low. Okay, 0.5 milligram to 1 milligram. For patients yang datang with, you know, all sorts of anxiety and depression and sometimes stress, all those kind of things, adjustment disorder, I usually tell them, I'm going to give you 1 milligram of clonazepam. All right, you take it around 9 to 10 p.m. Around that time. You record how much you take, what time you take, and do this for the next 5 to 7 days, and then you let me know what happens. Because what I want to know is that, are they suitable with 0.5 or are they suitable with 1 milligram? Because what happens if they take too much, in the morning they will report that, doctor, you know, pagi bangun nak sembahyang subuh, for Muslims, rasa berat sikit kepala, and then I just can't resume work. I need to sleep for a while. So I know that the dosage is kind of probably a little bit too much for that person. The second thing that I ask, you know, or the number 2 thing that I ask is, what time did you take those medications? Because if they take around 11 or 12, then we would know that, you know, the effect will be extended in that sense. So I ask them to take much earlier, maybe 10, maybe 9. Most of our patients, when they take the medication clonazepam at 9 p.m., they would probably fall off to sleep maybe 1 hour, 1.5 hours later. They get drowsy. It's different when you give short acting. When you give midazolam, when you give aprozolam, you give pukul 9, 9.20, 9.30, 9.40, dia dah start dah rasa sedated. Okay, dia dah start rasa effect tu. Not all, but most of the patients. That's why the selection of medication is important. So most of our patients yang, you know, they report, they get midazolam, they get aprozolam from clinics, banyak klinik jual kan. They're able to sleep. They take around 10, they sleep around maybe 10:30, 11, but then they wake up at 2 a.m., they wake up 3 a.m. because it's short acting. And that is why in my practice, I want to use something which can cover at least 6 hours. So that's why the clonazepam 0.5 to 1 milligram. And do patients get dependent? Do patients get dependent on clonazepam? As far as my experience is concerned, I don't see that. You know, like I said, I mentioned early on, maybe half or more than my patients would, doctor, I don't need clonazepam, I don't use it so much anymore, and I can sleep now, you know. Or if they do take 1 milligram, they take 0.5, or if they take 0.5 milligram, they say, you know, I just take it when I need it lah. So I understand that. So I'm not too concerned with dependence or tolerance with clonazepam in that sense. You know, you can try for yourself. So if you want to use for 2 weeks, it's okay. I have patients who are using 2 months, 3 months, and then they're doing quite well. You know, but monitor lah. I'm not just saying give back, then tinggalkan, monitor. All right, I'll stop here, and if there's any other questions or any other concerns, let me know. If not, I'll pass it back to Dr. Faiza.
Doctor, I have a question.
Silakan.
Okay. How do you manage the second part of the interrupted sleep? Let's say the patient already has already taken the benzodiazepine, and he is able to sleep. But at 2 o'clock in the morning, he wakes up and cannot fall asleep. Then how do you manage this part?
Right. Very good question. Okay. I'll just give you a case scenario because it's easy for us to focus on the things that we can improve. Patient is male, 40 years old. He works normal shift as a technician. He has sleep problems. Anxiety and depression is not so much of a concern. He takes clonazepam at 9 p.m. I ask all my patients to actually record what time they take. They take clonazepam at 9 p.m. So he's able to sleep at around 10, 11. He's able to sleep. He wakes up at 3 a.m. in the morning. Okay. And depending on whether this is something which happens most of the time or it just happens once in a while, it depends. But what I normally advise them is that if you need to take an additional 0.5 milligram at that 3 a.m., go ahead. No problem. Go ahead. And if they do take it and later on they report, I do take it at 3 a.m., but then I'm not able to wake up well in the morning, then sometimes I might convert that to providing PRN basis aprazolam, Xanax. PRN saja. It's not regular. It's just to help them with sleep. They need to sleep fast at 3 a.m. and they need short acting. So I just assist them with that. This is not long-term plan. This is just so that they're able to understand their body themselves. What's amazing is that when we empower patients about the medication, the dose, the duration, they are able to understand their body. All right. So if they do wake up 3 a.m., they have an option whether they want to try not taking medications or they can take medication under 0.5. Just explain to them the side effects, explain to them that, with clonazepam, there's low risk of dependence or tolerance. And just explain to them, kalau you do give Xanax or aprazolam, it's just going to be short-term basis so that you'll be able to go to work, so on and so forth. But the other point that we need, or I would explain to them, is that do not feel do not feel ashamed or do not feel afraid to share your sleep disorders or the sleep-wake cycle concerns with your supervisor. Share with them. Say you have this problem, you're getting treatment, you're on medication, and then sometimes these things happen. We need them to be able to talk to the supervisors. And in another setting, perhaps we can talk about how can supervisors help to assist patients with health concerns like this to recover or to be able to work optimally at work, because these are the things that we can't avoid. It's really disheartening to know that some doctors, they still go to work walaupun drowsy, walaupun tak cukup tidur. They go to work in the sense they drive to work tau, bukan go to work naik MRT kat Kuantan tak MRT lah. Or they go to work naik Grab. One of my patients, which was a healthcare personnel, said if you have a bad night and you can't drive to work, take Grab. If there's no one to send you, take Grab. Don't risk of driving. You mengantuk, you tidur, nak buat macam mana? Okay, so these are the things that we need to be of concern. One last thing that I probably want to share with you, my patient on Luvox, whether it's Luvox or Lexapro, low dose. Also on clonazepam, 0.5 I think. And also on quetiapine. Quetiapine ni sangat sikit lah, 12.5 mg. So kalau ada 25 mg tablet tu, dia kena patah dengan 2. And that is all that he needs to be able to sleep. And he has chronic insomnia in that sense. He doesn't have much of anxiety disorder. He doesn't abuse drugs. He doesn't have any other medical condition. And he's done a polysomnography and still waiting for the results from the sleep medicine specialist. But basically, because when you nak buat sleep study tu kan, you can't take medication for at least 5 days to 7 days. He was not able to sleep at all. And kalau dia tidur pun tidur ayam, and you can see from the EEG that when our EEG, our beta tu will be very frequent, very high kan. And walaupun dia tidur, dilaporkan tidur, his beta was still high, meaning that his brain is not sleeping. Okay, so that's why we use all this medication to help the brain to sleep, not just the person physically to sleep, but the brain to sleep as well. And this we can see from the EEG. Back to you, Dr. Faiza.
Very lengthy and fruitful discussion, yeah, because this is a lot of practical issues that have been facing. Okay, thank you very much to Dr. Faiz, and thank you everyone for joining us today. And I hope all this discussion will help you in your management in the primary care of the patient with sleep disturbances. Thank you and goodbye.
Thank you so much.
Assalamualaikum.
Goodbye. Salam.